topic is topical fluorides. Fluorides, actually, they form a part of preventive dentistry and they are very important in pediatric dentistry. Fluorides, they actually can be called as a double-edged sword because up to certain extent fluorides have a protective role, whereas if it crosses a certain limit, definitely it causes harmful to very harmful effects. So we need to know about these. Actually, fluoride can be divided into so many parts about history of fluorides. Then systemic fluorides, then topical fluorides, systemic among systemic fluorides. What are the different means of giving the systemic fluorides? Next, topical fluorides. Then how to calculate the optimum fluoride levels. Then if there are excess fluoride levels, how to remove the excess fluoride from water, that comes under defluoridation. And what are the adverse effects of fluoride, that is toxicity, among which acute toxicity is there, chronic toxicity is there, and management of the toxicity is separate topics. They all are very important questions for you people, but today we will be concentrating only on the topical fluorides. So if you think about topical fluorides, what comes to your brain? Definitely is the one that we daily use, that is a toothpaste. But apart from that, actually topical fluorides, it can be categorized into other ways also that you will learn in today's class. So topical fluorides can be broadly classified into two types, that is professionally applied topical fluorides and self-applied topical fluorides. So topical fluorides actually are the fluoride containing agents which are applied to the tooth surfaces in regular intervals in order to prevent the development of definitely dental caries. And I told you that it can be classified as either professionally applied topical fluorides and self-applied. So first we will see what is this professionally administered or professionally applied topical fluorides. Among these fluoride agents, there are many different types of these fluoride agents. Important ones are the 2% sodium fluoride, 8% stannous fluoride, 1.23% acidylated phosphate fluoride. Then comes the fluoride varnishes, and last but not least are the intraoral fluoride releasing devices. These are all separately, actually they are considered as a separate individual 4 marks questions. And intraoral fluoride releasing devices, it is sometimes asked as a 2 marks question, not only in pedo but also in community. This is very important, so please concentrate on what I am telling. So first type of professionally applied topical fluoride is the sodium fluoride, 2% sodium fluoride. It has been developed by Knudsen in 1947, and the pH of this will be 7, that is neutral pH, and the ppm will be around 9040. So this is very important for you people to by heart these things. So it has been developed by Knudsen in 1947, at like exact independence year. Then neutral, it will be having neutral pH of 7 and ppm will be 9040, that is 9040. Coming to the preparation of this sodium fluoride, 2% sodium fluoride is prepared by dissolving 20 grams of sodium fluoride powder in 1 liter of distilled water, and this results in formation of 2% sodium fluoride. Thus, this prepared 2% sodium fluoride should always be stored in plastic bottles. That is also an important point. Sometime asked in Viva how to store sodium fluoride. So it has to be stored in plastic bottles. So the method of preparation is dissolving 20 grams of sodium fluoride powder in 1 liter of distilled water. Then comes the application technique, which is also asked in Viva. What is the application technique for sodium fluoride? So the application technique for sodium fluoride is the Knudsen technique. So Knudsen technique is the name given for the, because it was developed by Knudsen, its the technique is also named as Knudsen. So before going into this slide, I just want to tell you what is the way to apply this sodium fluoride. First, we have to do thorough oral prophylaxis. Then it should be isolated. After isolation, sodium fluoride should be applied using cotton applicators. And actually, it is applied only once due to the formation of calcium fluoride, which prevents further diffusion of fluoride ions. So, repeated application is useless because once you apply a layer of sodium chloride on the tooth, what happens? There will be formation of calcium fluoride, which prevents further diffusion of the fluoride ions into the tooth. Thus, this phenomena is called as choking off phenomena, which is also a very, very, very important 2 marks question for you people in theory exam. So, choking off phenomena, if it's asked choking off phenomena, most of you will be thinking in which lesson this choking off phenomena has come, and you will be asking the invigilator. So don't do such useless silly things in the exam. Be professional. So you have to maintain the professional dignity. You just have to concentrate on all the classes so that you will definitely come across all the questions that are asked in the question paper. Most of the questions, 98% of the questions. Okay, so the choking off phenomena is the thing, is the formation of calcium fluoride on the tooth surface. Once it's applied, a layer is applied, there will be formation of calcium fluoride, which prevents further diffusion of fluoride ions, which is called as the choking off phenomenon. The patient should be asked to refrain from eating or drinking for the next 30 minutes. Then coming to the next slide, that is the number of applications. It's on seeing this, it's very easy to remember. Actually, you can see that you have to apply the sodium fluoride at the age of 3 years, at the age of 7 years, at the age of 11 years, at the age of 13 years, which is nothing but the age corresponding to the erection of new teeth. So in 3 years age, all the primary molars would have erupted. In 7 years, the first permanent molars would have erupted. In 11 years, premolars and second molars at the age of 13 years and premolars at the age of 11 years. So these are the ages which coincide with the erection of new teeth actually. And if you observe, at the age of 3 years, you have to apply in the first week. If the patient child enters into your clinic, in the first week you have to apply once, then second week you have to apply another layer of sodium fluoride, then third week, so fourth week. So every year the patient has to be recalled for 4 times. So 4 applications, and this is the disadvantage with sodium chloride, which we will be discussing in the further slides. Then coming to the mechanism of action. So thus when sodium chloride is applied topically, it interacts with the hydroxyapatite crystals, and I have already told you that there will be formation of calcium fluoride. This calcium fluoride is the actually dominant product that is formed, and it interferes with further diffusion of fluoride. And sodium fluoride is applied only once, and further applications serve no purpose due to this reason. So it is a very important point you have to remember, both clinically and for your exam sake and even for your viva. The calcium fluoride thus further reacts with the hydroxyapatite to form a fluoridated hydroxyapatite, and thus the fluoride content of the surface enamel is enhanced and in turn enables the tooth to resist this karyogenic attacks. So that's the mechanism of action of sodium fluoride. And coming to the advantages with this sodium fluoride, the compound that is formed due to mixing of this 20 grams of sodium fluoride in 1 liter of distilled water is actually chemically very stable, and the taste is acceptable, which is very important in pedo, and it is non-irritating to the gingiva and doesn't discolor the teeth. And actually the most important thing, the product actually is not expensive, that is it is inexpensive. So these are the advantages, that is it is chemically stable, it has acceptable taste, it is non-irritating to the gingiva. These are the plus points. In pedo, it doesn't discolor the teeth and it is inexpensive, which is important for the parents actually. So then disadvantages. So the main disadvantage that we have already discussed is 4 visits. So 4 visits and 4 consecutive weeks the patient has to come, and the parent also has to come for every course of application, which is difficult in the parent's point of view. So next, professionally applied topical fluoride is a stannous fluoride, which is 8% stannous fluoride. This itself can be asked as a 4 marks question, and it's very important in the Viva. So stannous fluoride solution, it has a pH of 2.1 to 2.3. So you have to remember that sodium fluoride had a pH, it has a pH of 7, that is neutral pH, whereas coming to stannous fluoride, it has a low pH, that is 2.1 to 2.3. And then the concentration of fluoride in this is high when compared to sodium fluoride. So sodium fluoride, it has 99,040, that is 9040. Whereas coming to stannous fluoride, it has a ppm of 19,360 ppm will be there. And coming to the preparation, it will be formed by mixing 0.8 grams of stannous fluoride powder with 10 ml of distilled water. This is the way to prepare this stannous fluoride. Whenever the patient arrives, a fresh solution will be prepared. You might get a doubt. There we have mixed 20 grams in 1 liter of distilled water and we are storing it in a plastic bottle. Whereas coming to stannous fluoride, it has to be prepared very fresh solution has to be prepared, and hence we are taking just 10 ml of distilled water in which we are mixing 0.8 grams leading to the formation of 8% stannous fluoride. And this stannous fluoride actually it will be pre-measured and will be mixed when the patient arrives, child arrives, fresh solution will be prepared. And while mixing this powder and water, another important point you have to remember is that you have to mix only in a plastic container. The solution should be fresh, and this freshly prepared solution should be always be stored in airtight capsules, as the solution actually it is very highly unstable. The tin component of the stannous fluoride is highly reactive and gets oxidized easily to its stannic form, thus reducing its anti-karyogenic efficacy. So it has to be freshly prepared, and as it is highly reactive, it has to be stored in an airtight capsule. Then coming to the application part, there we have discussed that the technique used for sodium fluoride will be Knudsen technique, wherein you will be isolating the teeth. First you will be doing the oral prophylaxis, isolating the teeth, and you will be just giving one coat of sodium fluoride, because there will be choking of phenomena, because of which your further absorption of fluoride will not be there. Hence you will be asking the patient to come after 1 week. So 4 consecutive weeks you will be applying at 4 ages actually, 3 years, 7 years, 11 years and 13 years, corresponding to the eruption of teeth actually. However, we are coming to this stannous fluoride. The method or application for this stannous fluoride is called as the Muller's technique, and it has been proposed in the year 1957. Whereas sodium fluoride was introduced in 1947. This technique has been introduced in 1957. So these are the things that you have to remember. And coming to the pH, there sodium fluoride is a neutral pH, so it is 7, whereas stannous fluoride the pH is 2.1 to 2.3, that is acidic pH. So in this Muller's technique, the first step is a thorough oral prophylaxis as done with sodium fluoride, and teeth has to be isolated. Then fluoride is applied using cotton applicator. The solution is applied using cotton applicators, and applied surfaces of the teeth have to be kept moist for around 4 minutes. This is a very important difference between sodium fluoride and stannous fluoride. There we will be just applying a single coat of sodium fluoride, whereas coming to the stannous fluoride you will be continuously wetting the tooth. That is, the application of application of the solution on the teeth will be continuous for around 4 minutes. So teeth have to be kept moist for 4 minutes. This is applied by reapplication. So application, reapplication. So every 15 to 30 seconds you will be again giving a coat of stannous fluoride, because here there will not be any choking of phenomena. This is a major advantage with stannous fluoride. So as mentioned with sodium fluoride, the next point will be the same. The patient or the child has to be refrained from eating or drinking for the next 30 minutes, and the number of applications, coming to the number of applications, it will be just once per 1 year. So once in a year, you have to apply this stannous fluoride. This is also an advantage. Then coming to the mechanism of action of stannous fluoride. When stannous fluoride reacts with hydroxyapatite of the dental enamel, fluoride as well as the tin combines with it to form a crystalline product known as stannous trifluorophosphate. This trifluorophosphate is highly resistant to decay. So what is the product formed is stannous trifluorophosphate. And this stannous trifluorophosphate and other end products will also be formed along with this stannous trifluorophosphate. They are the tin hydroxide hydroxyphosphate, then calcium trifluorostanate and calcium fluoride. These are the things that will be formed. So the end products formed due to reaction of stannous chloride with hydroxyapatite or the stannous trifluorophosphate, tin hydroxyphosphate, calcium trifluorostanate and then calcium fluoride. At low concentrations, actually, stannous trifluorophosphate and tin hydroxyphosphate are formed. So, first things are formed in low concentrations. Whereas at very high concentrations, stannous trifluorophosphate and calcium trifluorostanate are formed. So, in high concentrations, first and third one will be formed. It is essential to observe formation of stannous trifluorophosphates which have the anti-carcinogenic effects in both high and low concentrations. Calcium trifluorostanate that is formed only in high concentrations is also believed to have anti-carcinogenic action. Additionally, calcium fluoride, which is the fourth thing that is formed in very small quantities as one of the end product at both low and high concentrations, this combines with hydroxyapatite to form a fluorhydroxyapatite. Thus, everything is important here except in hydroxyphosphate, which is formed in low concentrations. In low concentrations, actually, first two will be formed, among which stannous trifluorophosphate is having anti-carcinogenic properties, whereas at high concentrations, stannous trifluorophosphate and calcium trifluorostanate will be formed. Both will be having anti-carcinogenic properties. So, definitely, high concentration is more beneficial when compared to low concentration, and hence you have to repeatedly apply the solution on the teeth. So, repeated application is to attain a very high concentration of stannous chloride, which reacts with the hydroxyapatite to form two products, that is stannous trifluorophosphate and calcium trifluorostanate, which both are having the anti-carcinogenic properties, and along with this calcium fluoride will be formed in very small quantities, which reacts with hydroxyapatite to form fluorhydroxyapatite. Thus, this is a mechanism of formation of the products formed actually. So, this is a diagrammatic representation actually. Stannous chloride reacts with hydroxyapatite to form stannous trifluorophosphate, which is anti-carcinogenic. And low concentrations, what is happening? Tin hydroxyphosphate is forming, which will have an additional disadvantage of giving a metallic taste, which is highly unacceptable for a child. So, in low concentrations, there will be formation of tin hydroxyphosphate, which is giving two disadvantages. That is, it is not having anti-carcinogenic property, and additionally, it is giving metallic taste. Then calcium fluoride is formed in both actually. So, calcium fluoride. Then in the second diagrammatic representation, actually, this formed calcium fluoride reacts with hydroxyapatite, leading to formation of fluorhydroxyapatite. At high concentrations, what's happening? Stannous fluoride, hydroxyapatite reacts to form stannous trifluorophosphate, and additionally calcium trifluorostanate. Both are anti-carcinogenic, and additionally calcium fluoride will be formed. This calcium fluoride, which is additionally formed in low concentrations, reacts with hydroxyapatite with the diagram shown for the low concentrations, which leads to formation of fluorhydroxyapatite, which is anti-carcinogenic. Right. Coming to the advantages, rapid penetration of the solution within 30 seconds. And the complex that is formed on the enamel surface, it is more resistant to decay than enamel itself. These are the general advantages, not any specific advantage. But the main advantage is that one application for 1 year is the main advantage with stannous chloride. Whereas many disadvantages are there with this product. That is, it is highly unstable. Thus, we are freshly preparing the solution. It has a metallic taste because of the formation of tin hydroxyphosphate. Then it causes gingival irritation, and discoloration of teeth will be there, and staining of even margins of the respiration is another disadvantage with stannous chloride. So many disadvantages, hence stannous chloride. Acceptance of stannous chloride in pediatric dentistry is somewhat questionable. Then coming to the third thing, that is acylated phosphate fluoride, 1.23%. So this is again a 4 marks question for you people. So acylated phosphate fluoride is actually an acidified sodium fluoride with phosphoric acid in order to gain more depth of penetration of the fluoride when applied on the tooth. So it can be actually, it can be as made as a solution or in a gel form. Coming to the pH, the pH of APF solution will be 3, around 3, and the APF gel it will be around 4 to 5. So when it comes to pH, it's less than the sodium fluoride because we are adding phosphoric acid here to the sodium fluoride in order to increase the penetration of fluoride. And then, but it will be more compared to the stannous fluoride. Stannous fluoride, the pH will be 2.1 to 2.3. And coming to the ppm of fluoride, it will be having intermediate actually sodium fluoride and stannous fluoride. When we compare both the things, it will be in the middle actually. The ppm of fluoride, the fluoride concentration in the solution will be 12,300 ppm actually. So in between sodium fluoride it is having 9040, whereas stannous fluoride it will be having 19360. So 19,360, whereas coming to APF it will be 12,300. Coming to the preparation of this solution, preparation of this solution, acylated phosphate fluoride solution is prepared by dissolving 20 grams of sodium fluoride in 1 liter of. There you will be mixing 20 grams of sodium fluoride with 1 liter of water, whereas here you will be mixing 20 grams of sodium fluoride in 1 liter of 0.1 m phosphoric acid. That's the main difference. In order to adjust the pH to 3 and fluoride concentration to 1.23%, you will be adding 50% hydrofluoric acid. So that is an additional point we have to mention definitely. So first solution will be prepared by mixing 20 grams of sodium fluoride in 1 liter of 0.1 m phosphoric acid. Then in order to adjust both the pH and fluoride concentration, you will be adding 50% hydrofluoric acid. And gelling agent in order to form the gel is methyl cellulose or the hydroxyethyl cellulose. And the pH of the gel will be adjusted to 4 to 5 as already mentioned. And coming to the application, the oral prophylaxis is a must. Then teeth will be isolated with cotton rolls. Then solution will be applied using cotton applicators. These are the common points for any solution. And then the teeth has to be kept moist for 4 minutes. This is the same as Muller's technique for stannous fluoride. And floss is passed through interproximal embrasures, and the gel form of APF is applied using trays. The tray is inserted and the patient is asked to bite tightly for the same 4 minutes, and the gel thins out under the biting force because of its thixotropic nature. And the saliva ejections are used during this application, and patients should not be allowed to eat or drink anything for the next 30 minutes. Recommended number of applications per year is twice, whereas stannous fluoride it is 1 per year. Here you have to apply twice per year. And coming to the mechanism of action, when APF is applied initially, it leads to dehydration and shrinkage in volume of hydroxyapatite crystals, which on further hydrolysis forms an intermediate product called the dicalcium phosphate dihydrate. This is the important thing that is formed. So, intermediate product that is formed is because of the reaction formed is the dicalcium phosphate dihydrate. This is actually asked in Viva. This DCPD, nothing but dicalcium phosphate dihydrate, is highly reactive with fluoride and starts forming immediately when the APF is applied. So fluoride penetration leads to formation of fluorapatite. So coming to the advantages, the fluoride applied will be more 50%. It is more effective when compared to sodium fluoride. Stable because of the long shelf life when stored in plastic bottles. Then it is inexpensive, easy to prepare. And coming to the advantages with the gel form is you can flavor it in order to make it more acceptable for the kids. This is most common mode of application for children in pediatric dentistry. Easy to apply. The gel form is easy to apply because we can just ask the child to bite on the tray which is filled with this APF gel. And repeated reapplications are not required because you will be pouring the solution into the tray and just keeping the tray in the mouth for 4 minutes. Even self-application is possible with the APF gel form. And caries reduction will be more actually with this APF, more compared to this APF solution when solution and gel are compared. And coming to the disadvantages with this solution, definitely is acidic because 3 pH is also acidic. So it will be sour and bitter in taste, and teeth must be kept moist when coming to the solution part. The teeth have to be kept moist for 4 minutes And the prolonged exposure of composite restorations can result in surface roughening. And coming to the disadvantages with the gel form, it can cause irritation to the inflamed gingival tissue, and irritation to the open carious lesions is also possible. Next mode of professional application is the fluoride varnish. These fluoride varnishes are developed in order to increase the retention of topical fluoride onto the enamel for longer period of time. The reaction time of fluoride with enamel is also increased, thereby providing improved stereostatic action. Here some commercial names you might have heard. First one is a Durafide. It contains sodium fluoride, and the ppm will be around 22,600. Actually, all varnishes, the ppm of fluoride will be more compared to the previous ones. The varnish, actually, as it is a varnish form, it sets rapidly whenever applied to the teeth, when in the presence of moisture, actually, and it remains on the applied tooth surface for up to almost 12 hours after application. Then next commercial product is a floor protector. It is actually 2% difluorosilane, and the ppm will be 7,000. And coming to the procedure of application, this actually is about the floor protector itself. The varnish, it is made up of polyurethane lacquer, which is dissolved in chloroform, and it is available in 1 ml ampules actually. Then coming to the varnish application procedure, thorough prophylaxis is a must, and teeth have to be dried and varnish applied over all the teeth surfaces. Cotton rolls should not be used because the varnish sticks to the cotton rolls, and patient should be instructed not to close the mouth and remain with the mouth open for 4 minutes till the varnish gets dried up, and the patient should be asked to not to eat or drink for almost 1 hour. So prophylaxis, then drying, then varnish application. Cotton roll should not be used because varnish sticks, and patient should be instructed not to close the mouth. The patient has to remain with the mouth open for 4 minutes until the varnish dries up. Then they have to be asked not to eat or drink for almost 1 hour. Then coming to the actually, the intraoral fluoride releasing devices should be there. These intraoral devices, they actually predetermined quantity of fluoride will be released inside the mouth over a prolonged period of time when attached to the tooth surface. That's the main advantage with this fluoride releasing devices, because they will be having that rate controlling mechanism will be there. Then coming to the fluoride dentifrice, this is the common thing that we use daily, routinely, and the compounds that will be present in the fluoride dentifrices will be either sodium fluoride, stannous fluoride, monofluorophosphate, or the amine fluoride. And high potency fluoride dentifrices will be having greater than 1000 ppm of fluoride, whereas low potency fluoride dentifrices will be having less than 1000 ppm, which are commonly called as the child formula dentifrices that I have already covered in the plaque control measures. Then comes the fluoride mouth rinses. These fluoride mouth rinses, they are actually adjunct to these dentifrices for caries control and prevention, and they provide almost 30 to 35% reduction in dental caries. They are actually home care aid by individuals, and they can also be given as a part of school-based programs. And commonly used mouth rinses or 0.2% sodium fluoride and 0.05% sodium fluoride, 0.01% aspirated sodium fluoride, and the ppm will be first one 900 ppm, then 225 ppm, then 45 ppm, or even stannous fluoride mouth rinses are also there. And coming to the procedure of mouth rinsing, 10 ml of mouthwash or mouth rinse has to be swish. The child has to be asked to swish it in the mouth, and then the remaining has to be expectorated. And the patient the child has to be instructed not to eat or drink anything for the next 1 hour. This is the common thing. This actually intrafluoride releasing devices that I already told you in the beginning itself. So this completes the topical fluorides. So today we have discussed what exactly is the topical fluorides, uses of topical fluorides. They are classified as either professionally applied and self-applied. And among the professionally administered topical fluorides, we have discussed about sodium fluoride, stannous fluoride, APF, that is acetate phosphate fluoride, varnishes, and then these releasing devices. Then comes the self-applied, among which important ones are the fluoride dentifrices and fluoride mouth rinsers or the mouth washes. This completes this topic. So just go back, open the textbook and have a look at the theory part in the textbook. It will be very easy for you. It will be like a review.